We are live. Happy Friday, everybody, and good morning from the West Coast. I am your head witch for today for this pre-Halloween weekend workshop. Thank you for not being too scared of data disaggregation to join us for this very important work. I'm going to start by opening with UCLA is a land grant institution, and here at UCLA, we pay tribute to the Gabrielino and Tongva peoples as the traditional caretakers of the Los Angeles Basin and South Channel Islands. And so in that spirit, we are going to get started today with a very important and very valuable workshop on the wonders of data disaggregation. For those of you who are new to our workshop series, please make sure that I have the power to mute you in all of my spell casting, but we have both a chat and a Q&A function. We'd like you to use the chat for general comments and discussion, and use the Q&A function if you have questions that you'd like the panelists to answer. We are reserving time at the end for a lot of discussion, and so we want to hear from you. Welcome to the National Network of Health Surveys. Our mission is to help data collection and data users across the country who work with population health to have access to high quality data, and hopefully that's comparable across the US. As you see in this current pandemic, we're all facing the same thing. And so having good, valuable information that's similar across the country can be invaluable when public health officials need to make good evidence-based decisions. So that is our mission. However, I don't want the word survey to scare you off. The methods that we are talking about for race and ethnicity data disaggregation is valuable for all kinds of data collection and data use practices. And so while we are grounded in surveys, we certainly are going to talk about principles that have much broader application. So we are, thanks to support from the Robert Wood Johnson Foundation, advancing the disaggregation of ethnic racial data through technical assistance, training, and case making. And this is our technical assistance and training portion of that program. We want to improve the collection, the processing, and the reporting of disaggregated race and ethnicity data to address health disparities and improve health equity and outcomes. And so we are going to conduct these major workshops, and then after the workshop today, all of you will receive a link to a survey. Please tell us about your technical assistance needs, as we're going to devise more sessions to get really hands-on with the barriers that you may be facing, because we want to help for everybody. We have a series of workshops. If you missed the last one, no worries. It is recorded and on our website. We are on the second one today, and we have 4 more scheduled. Please, if you registered, you are signed up for all of them. And again, if you miss any of them, they will be available for viewing later. But today, live from New York, we have Martha, April, Stephanie, and Michael. They are in one of the most diverse cities in the United States, and they have a unique duty and unique challenges to collecting and representing the true population that they serve. And so they're going to work with us today on ways that they are addressing data disaggregation in their many different collection. They have surveys, they have other data sets that they work with, and they are working across all of them to try to improve so that all of the data sets that you would get from them are going to fairly and efficiently represent the city that they serve. So I'm going to hand it over now to Michael to get us started.
Hi, this is Stephanie. I think I'm actually starting. It's nice to see everyone. Thanks for joining us on the Friday before Halloween. We are some members of the New York City Health Department and Mental Hygiene, and we want to share spooky stories of data and equity. Keeping with Halloween and just noting thematic threads of haunting that we'll sort of identify as we focus on equity throughout the presentation. If we could go to the next slide. We'll introduce ourselves. My name is Stephanie Farquhar. I am the Director of Social Research at the Center for Health Equity and Community Wellness at the department. And we also want to share one thing that we've that evolved in our thinking to demonstrate that like we don't have all the answers and we're continually making progress and we're continually getting things wrong. So one of the things that I've really enjoyed changing over the last few years is really trying to work with an intersectional lens and trying to figure out how to do that with small sample sizes. And I'm going to pass it off to my colleague, April.
Everyone, my name is April. I am the Child Health Survey Manager at the New York City Department of Health and Mental Hygiene. I work in our epidemiology division in our Bureau of Epi Services. And I'd say one lesson learned or one area that I've really come to improve upon is more on the end aspect of our data once it's all collected and we're doing recodes, which is something I wasn't familiar with when it came to race ethnicity data. For those who wrote in their race or ethnicity, is recoding that. And it was very illuminating to see how we did that and the ways that we could improve that. So that's something that's really stuck with me. I'll turn it over to Mike.
Good morning or afternoon, everyone, depending on where you are watching this from. My name is Michael Sanderson. I work in the Division of Epidemiology on our larger population-based surveillance surveys. And I think one area of growth that I've experienced over the past few years is kind of coming to the realization of how important it is that the people we're asking to do our surveys can see themselves in the data, especially when it comes to race, ethnicity, and gender identity or sexual orientation. And kind of related to that is this, in survey work, we don't want to change the questions if they've been asked before because then we lose our trends. But I think we shouldn't necessarily be afraid to do that because the way people describe themselves changes over time. It's not static, it's dynamic. And I think it's important to consider that when we're reviewing our surveys and not just put in the standard demographic questions that we've always asked. I'll hand it over to Martha.
Thanks, Mike. Thanks, everyone. As you heard, my name is Martha Alexander. I'm the Data Communications Outreach Analyst. I work with Mike and April in our Bureau of Epidemiology Services and the Division of Epidemiology at the New York City Health Department. For many years, I worked in tuberculosis control as a health educator and health communicator. And the main fact we always talked about was that most people diagnosed with TB in New York City were born outside of the US. So we always worked with this dichotomy of non-US born and US born. But really, when you start to look at it, some people had been here for 25 years and some were more recent arrivals. So it wasn't until I started learning more about structural racism and how to name it that I started to realize how to message more around other risk factors to give a really richer understanding of the situation and better messaging to the people who we wanted to reach without stigmatizing them or oversimplifying what was going on. So Stephanie?
Great. Yeah, we're really excited to talk to you today. So I'm going to kick us off with a couple of guiding principles and theories. So the first one that we really like to go over, next slide, please, is talking about how demographic data measures social constructs. And I want to be really clear. When I say a social construct, I mean something that's designed by humans and subject to all of our biases and imperfections and creativity. However, people often hear not real when I say social construct. So I love using an example of something else that is a social construct. So right here we have an image of an object that is made of cotton and linen that has no value or meaning outside of the value and meaning we attach to it. However, so it's a socially constructed object that we collectively assign value and meaning to. But just as a dollar is very real and very powerful and has a lot of impact, so are the categories of lived experience that we're trying to describe when we collect demographic data. So moving on to the next slide, we also want to name that social construction almost always reflects oppression. And it's really important when we're thinking about this to really name the intersecting systems of oppression, whether it's racism, classism, nativism, heteropatriarchy, ableism, ageism. And we find at the health department that Iris Young's definition of oppression is very useful. We've included it here. And I think one of the key points is that oppression reduces the potential for other people to be recognized as fully human. And Young also named the way in which oppression operates through exploitation, so the act of using labor of others for profit without fair compensation, marginalization, which is the act of excluding or confining a group of people to lower social standing or at the outer limit of society, powerlessness, a lack of decision-making power, cultural imperialism, so when the culture of the ruling class is established as the norm, and then violence, so physical, psychological, or emotional attacks intended to damage, humiliate, or destroy a person. So we can see that oppression comes out in a lot of different ways. So looking at the next slide, we wanted to examine the social construction of race in the US, looking at US Census data. I'm sure many of you are familiar with this, but I really love what Pew Research did, and there's a link to it at the bottom of what census calls us. So they mapped out from 1790 to present day all the different racial categories that have appeared as options on the census. And looking at this diagram, I just want to point out a couple of social constructions. So the first is that at the top, you can see that white doesn't really change over time. It's very essentialist, even though we know that people are moving in and out of this category over time and over different periods. Another social construction that I think is really interesting is that the sort of like big groupings of categories we use that are color coded here really are closely track with Johann Blumenbach's 5 races that he published in 1779. And then, to keep with the Halloween theme, proceeded to spend 20 years studying 60 skulls to validate. So, you know, it's all of these categories are deeply embedded within our own power relations. And so I feel like, moving on to the next slide, I feel like folks are generally comfortable with the idea of the social construction of race, but the social construction of gender, it is a relatively newer concept. And when we were putting this presentation together, I just went into like Google Forms really quickly to like, you know, drop an example of like what a slide about gender would look like. And I had the most fascinating discovery that when I typed in "what is your gender" as the question, it auto-populated and auto-filled, and these were the responses: female, male, refuse to say, or other, right? So right here, again, we have the social construction of a gender as binary. And while it's like allowing for other options, it's not specifying and it's not inclusive. So it's really pushing other gender identities to the margin. It's also using, you know, terminology which we would identify as sex. So female and male is generally sex assigned at birth rather than gender identity. So, you know, it's really important to name that, like, when we collect data, all of our ideas about how people are assigned value within hierarchies are reflected in that. So moving to the next slide, we also want to name that data is an act of power, and that naming and counting things are acts of power. This is an example that I think a lot of folks are familiar with. On the left, the redlining maps that have been released from the National Archives since about 2014 have been made public, which is fantastic. But I want to point out how much data is embedded within what neighborhoods were considered desirable or undesirable, and how much the proportion of demographics are driving what neighborhoods got redlined. So this is an example of a neighborhood in the South Bronx, which had, quote, Negro and Puerto Rican, sorry, it's so tiny, but the word is really important. I can't read it, but please try and scroll your screen. But it's this sense of like creeping influence, right? And then, you know, infiltration. Thank you, Kate Wiley. So this idea of infiltration, right? So problematic, but like, it's there and it's presented as very scientific, and, very neutral. And also just naming that sets up other power structures like urban renewal. The picture on the right is a picture of the construction of the Cross Bronx Expressway, in which that neighborhood was bulldozed because the people who lived there were considered undesirable infiltrators. And that like demographic data supported that. So on the other hand, looking at the next slide, naming, count, and counting are also acts to access power. So this is a picture of a really fantastic group out of New York called the Coalition for Asian American Children and Families, who have done a lot of advocacy around increasing options for data disaggregation. Because Asian is this like huge nonsensical category, there's so much invisibility around the different groups whose lived experiences are sort of wrapped into that. And so they've been able to successfully push legislation at the city level. And then on a more national level, the advocacy for Middle Eastern and North African groups, while it didn't make the census this year, has also been another example of how people are trying to name things and measure them so that they can have access to the Voting Rights Act, and they can influence policies that impact them, and also monitor and measure discrimination. So to the next slide, just a pause to ask, when we collect demographic data, what are we actually trying to do? And what we're trying to do is to assess lived experience at a particular moment in time. And this means we have to be extra clear on what our hypotheses are to direct how we collect data and also how we disaggregate it. So I want to pause here and have a bit of an interaction in the chat. And here are 6 categories that are on lots of surveys, right? Asian, LGBTQ, Indigenous, Puerto Rican, Caribbean, Latinx. And I want to ask folks in the chat to name what are some of the diversities in lived experience that might be aggregated under these labels. So for example, for Puerto Rican in New York, you have folks who identify as Puerto Rican whose families moved here between 1940 and 1960 in the huge 1 million person migration from the island to the mainland of the US, which is really different, a very different lived experience than people who migrated to New York after Hurricane Maria, right? So that's just one example. So if folks can type in the chat what some other diversities of lived experience might be aggregated under one. So we have SES, thanks Kate. LGBTQ, it's a huge umbrella term which includes sexual identity and gender identity and sexual orientation, absolutely. Religious affiliation and language. And generation, absolutely. Country of birth, countries of origin. Voluntary and forced migration experience, for example, refugees, that's a great one. Lived experience of poverty. Puerto Rican doesn't define race, absolutely. Indigenous to where, right? These are all really important questions that if we're trying to answer something, we need to carefully think through when we're creating demographic categories. So bonus, you guys are super on board. White, rural versus urban, there's so much nuance in each of these categories. So keep it coming in the chat. I'm going to move on to the next slide. So what can people who work with data do about this? So you're going to hear from some of my colleagues about some of the work we've done at the New York City Department of Health and Mental Hygiene with data. I also want to just share some principles and resources to work with. So the first one in the next slide is to just sort of monitor and adopt emerging protocols. This is an example of a guideline that came out in 2019 called the Child Trends Guide, which has really great information about how to incorporate a racial and ethnic equity perspective throughout the research process. So again, naming that it's not just about one piece of it, not disaggregation, not collection, it's about the whole spectrum of what we do with data. The next piece is really committing to internal reform of the self. I say this as a woman who identifies as cis, white, and queer. And, building on Kimberly Crenshaw's really groundbreaking work in 1989 on intersectionality. And I shared just for those of you who aren't familiar, just a clip of the article on the left, how we identify our own lived experience really shapes how we name and interpret oppression. And each of us, each of us really have to acknowledge our own biases and where we need to grow. And as we mentioned at the top, this is an ongoing process and we constantly get things wrong and we're constantly growing. And I also want to invite folks to explore a really nice graphic called the Wheel of Intersectionality, which is, it centers one's own personal lived experience in the center and then weaves it in with systems of oppression at different levels, which I think is really helpful. So on the next slide, beyond internal transformation of the self, we also, it's really important to do internal reform of our institutions. So at the Department of Health, we've been very, very lucky that under Dr. Mary Bassett, when she was commissioner, she began an initiative called Race to Justice, which is an internal reform designed to advance racial equity and social justice. And it is a tremendous effort that has really pushed us forward internally and is led by staff, but leadership is also responsible. So that's one example of like leadership commitment to improving equity across the board that I think is really important. But there's also a lot that we can do as individuals who work within institutions. The next is just, again, learning our local history and context. I love this map. People are probably like, what is this? This is a map that the Dutch drew of Manhattan when New Amsterdam was an initial colony. And what it's kind of hard to see, but what you can see is that there's this like dividing line in the map, which PS is Wall Street. And to the right of it is all the Dutch colonies. And what's very subtle is to the left of it is where free Blacks were able to live. So basically the Dutch positioned people who had been enslaved as a protective barrier against any potential raids from people who were living there when the Europeans arrived. So racial segregation has been baked into our city since the go. So just, understanding that all of this informs how our city works and how systems of oppression work. And the last piece is really urging everyone to really put data in a historical, political, and experiential context. We've talked a lot about experience, but I also just want to point out two different examples of how to present data on COVID, for example. On the left is from the COVID racial data tracker, which does just like a pretty standard, here are the racial categories and here are the disparities, and God, it's bad. But there's not a lot of context for why it's bad. And on the right, Color of Change has put together a really tremendous response to COVID, like calling us out, us being data people, for telling the wrong story because we're not contextualizing any of the inequities. So telling the right story on race, they are suggesting if we're going to talk about Black-white disparities in COVID, we also need to talk about government oversight, about the prison system, about work life, personal life, home life, small business, healthcare, and government access, right? So the context is really important and we have to frame it. So with that, I'm going to pass it off to my colleagues, Mike and April, to talk about data instruments in New York City.
All right, thank you, Stephanie. So the health department has, a lot of data and a lot of different mechanisms for collecting data. Next slide. But I'm going to focus on some population-based survey tools that we have in the Division of Epidemiology. And I'll just briefly touch on each one, and then the remainder of my slides will focus on the community health survey. So the New York City Health Department conducts a variety of population-based health surveillance surveys, starting with the community health survey, or as we call it, the CHS. This is a survey of adult New Yorkers. It's done annually since 2002. The next is NYC Kids. This is done every other year. Starting in 2017, we kind of made it an actual surveillance survey that would be repeated every couple of years. Before that, there had been some some standalone surveys, but we really institutionalized it in 2017. And this focuses on kids 1 to 13. So a parent or guardian answers questions on behalf of a randomly selected child in the household. Both of these two first surveys have historically been done using telephone methodology, RDD. NYC Kids has used administrative records from birth certificates as well as student school health records to sample households with children. And they're both moving to an address-based design of self-administered in 2021. So we're kind of excited about that. The third is the Youth Risk Behavior Survey, which focuses on middle school and high schools in New York City. So all of these surveys together cover the entire population across the life course. And so we can get a snapshot of how these different population by age groups are doing. Next slide, please. So the slides I'm going to present now, I'm going to talk about are specifically focusing on our racial and ethnic questions. They are by no means the end all be all, but we've tried to improve them over time to be more inclusive than when they started. So when the CHS first started in 2002, all we asked were some pretty basic ethnicity and race questions. We asked about Hispanic or Latino ethnicity, and then which one or more of the following would you say is your race? White, Black, or African American, Asian, Native Hawaiian or other Pacific Islander, American Indian, Alaska Native, or something else. And these basically reflected standard OMB categories that a lot of different surveys collect data on. We also had a third question that we eventually dropped. Which one of these groups would you say best represents your race? And this was for individuals who identified as more than one race. And we realized, through thinking and talking about it, that this was actually kind of an offensive question to try and make someone choose one race over one racial identity over another. So we dropped that a while ago. Next slide. This just provides a brief overview or timeline of some of the changes that have been made to the CHS race and ethnicity questions, as well as future changes that we'll be fielding in 2021. Next slide. So in 2003, we added a question to capture Latino origin and ancestry. And there were a couple of limitations with this approach as this question was worded for a long time that became more apparent as we continued with data collection. First of all, Latino New Yorkers may identify with more than one of these groups, but the question did not allow for a multiple selection. It also didn't allow for an other specify option. Individual groups were also limited and did not really include many individual countries or peoples from Central, South, and Latin America. And as the population of New York City has grown and changed over time, this list became more and more dated. We were getting about 25% of Latino respondents who were being reporting some sort of other category. Next slide. I'm going to come back to the Latino question in a few slides. But in 2012, we added a question similar to the Latino heritage question on Asian heritage. And this was asked of anyone who endorsed Asian as a race in the race question. And these groups were based off of ACS data representing the larger groups of Asian populations within New York City. One improvement for this question is that we did allow another specify option, but it was still restricted to one response. Next question, or next slide. In 2017, we had read about some of the work that the Census Bureau had done as far as race and ethnicity questions, and felt like there's a large population of Middle Eastern, North African communities in New York, and that it was important to include this in the main race question. In a lot of data sets, including the census, many times individuals who are Middle Eastern or North African are coded as white, but this is a political decision more than anything. We wanted to allow these individuals, help these individuals be able to see themselves in the data. Next slide. So in 2019, we reviewed some of the larger Latino groups with current ACS data, and we made some changes to the response set. So we reordered some of the questions, or some of the categories, so that they reflected the size of the population within New York City, Puerto Rican being the largest. We moved Dominican and Mexican up in the list. And then we added 2 South American groups, Ecuadorian and Colombian. We also added a something else, an other specify option. And we did this change in 2019, and just over the course of a year, the percentage of Latino respondents who were answering in an other category went from 27.6% to 16%. So to us, this showed that we were doing a better job in capturing the diversity of the Latino population. Next slide. In 2019, we also added a Black heritage question. So this was asked of anyone who identified as Black or Black American. And we designed this question to be a multiple select with 3 main categories: African American, Caribbean or West Indian, and a recent immigrant or the child of recent immigrants from Africa. And we also included an other specify option for this. Next slide. In 2020, going back to the main race question, we worked with some community groups, did some qualitative work. There is a fairly large population of American Indian or Indigenous groups in New York City. And in talking to different community groups, we realized that this term American Indian or Alaska Native that had been used up to this point in the survey was very limiting. And to many people, they felt it was offensive. They don't consider themselves to be American Indian. They consider themselves to be a people. So we expanded the language on this in this category to include American Indian, Native, First Nations, Indigenous peoples of the Americas, or Alaska Native. Next slide. And then in 2021, when we go into the field this next spring, we're going to be adding an Indigenous heritage question. The groupings that we provide are based off of research that we've done that have identified groups of original peoples here before Europeans ever arrived, as well as Central American, Mexican American Indian, and Southern American Indians, with examples of some of these groups. So we're going to be fielding this in 2021, hoping to be able to do a better job of representing the Indigenous communities in New York City. Next slide. We're also asking a follow-up question, asking about tribal affiliation, specifically if it's recognized by the US federal government, a state government, or a government in another country, or if it's not a tribe that's recognized by any government. And we did it this way because there is not a lot of, there are tribes that are recognized by the federal government or a state government, but not both. There's also a lot of Indigenous people that have immigrated here from Central, South, and Latin America, and some of those countries also recognize different tribes. So that's why we structured the question in this way. And then just a little bit about further changes that we'll be implementing in 2021. April will touch on this a little bit more in the next section, but we're going to be alphabetizing race categories. And all heritage questions will be made multiple selection with an other specify option. And I'll hand it over to April.
Great, thanks, Mike. Okay, now to continue our spooky tales of data, we'll be talking about our child health surveys that we conduct here, starting with our New York City Kids Survey. If you could advance to the next slide, please.
April, as you go through this, could you note whether or not you use the term Latinx? We have that question from the audience.
Oh, yes, the term of Latinx in our questionnaires, is that the question?
Yes.
In our questionnaires, no, so that's an agency policy, and that's something that we can discuss more towards the end of the survey, because I know that's something that all of my other colleagues may also want to chime in on. But that is more of an agency policy where within our surveys, we don't use the term Latinx. Okay, so transitioning into race ethnicity, Mike spoke a great deal about all the changes we made, so I won't go into detail about those. I just wanted to lay out here, as you can see, we started the New York City Kids, making it a standard part of our surveillance in 2017. You can see the bit of a roller coaster it's been with incorporating race ethnicity into our surveys, into this particular survey. And I'd say, a lot of this was mainly due to space limitations. And I think that's something that we are being more intentional about, is making sure that limited space doesn't hinder us from asking important demographic questions such as these. And that also gets back to Stephanie's points about visibility, especially when it comes to policies that impact our youngest New Yorkers. We want to make sure that they're seen in this data, and that we can disaggregate as much as possible. So I'd say also, it's definitely a positive working together, in our surveys team, working on all of this and improving all of our surveys as a whole, to ensure that it's not a siloed process. Next slide, please. Okay, so I'd say another change that I'd like to highlight is our improvement of the Nativity question that's asked on our surveys. So we've noticed differences among how our surveys were classifying US territories. So I have here on the left side, you can see in kids from 2017 to 2019, we just had two answer choices, and it was either you're born in the US or you're born outside of the US. So if you were born in a US territory, in kids, that was classified as being born outside of the US, but that wasn't the case for all of our surveys. So in order to get some consistency, we knew we wanted to improve this question, but also, something that's important to note is that out of our survey team, none of us were born in US territories. So who are we to make this decision? So we decided to reach out to staff among the agency who were born in US territories and could provide more of the background and lived experiences around this question for them. And a lot of it came down to, internalization of the question wording is, if being labeled as outside the US, feeling as if you're not American, even though you were, raised to believe that you were, but according to this data, you're not. But, if we lump them into the USA category, then we wouldn't be able to capture the differences among populations. Like Stephanie also talked about, Puerto Ricans who are born in mainland USA versus Puerto Ricans that are born in Puerto Rico. We've seen that there are different health outcomes, and we wouldn't be able to glean that if they were aggregated within US. So with, after having, several of these conversations and focus groups, we came to a good improvement here that we have here on the right side of just making sure that US territories were their own separate choice, so that that can be disaggregated throughout. And we can advance to the next slide. And then also, so Mike briefly touched about this. I said these small but mighty changes, as most of these are, if you think of the grand scheme, adding one thing here, one thing there could be small, but can mean a whole lot to the people who identify with, that one category that we added or whatnot. So I'd say with kids, one change that we made was switching to gender neutral language. In 2017 and 2019, we asked about if the child was male or female at the beginning in the screener, to code for the questions and use language as like him, her, he, she, himself, herself. And we decided not to do that for 2021, and instead ask the sexual orientation question, gender identity towards the end in the demographic section with all the other demographic questions, and instead just change to using neutral language such as them, they, their. And as Mike also said, we have gone to alphabetizing our answer choices for race, ethnicity, and SOGI questions. You know, what I like to ask myself is, why does male and why does white why do those always have to be the first answer choices? So that's something that, as someone who is not white and not male, that I definitely notice and, you know, bothers me. And, you know, I believe it perpetuates this notion of superiority. So in order to be more neutral with that, we decided alphabetizing was the best too. Okay, and then I can move on to our next survey here, which is our youth behavioral risk survey. And just context, Mike might have mentioned this too, but we do conduct this for both high school and middle school. And I'll talk about our race ethnicity questions first. So YRBS, this is actually our longest running survey. We started leading the YRBS within our agency in 2003. And for a bit of context, YRBS, it's different from our other surveys since it's a national survey operated by CDC. And so that means that we don't have the level of autonomy to make changes to every question like we do with our other surveys. We also partner with the New York City Department of Education, who also review and have a say in question wording. So there is more of there's more to this review process when it comes to survey development. And YRBS, they actually, the CDC provides a list of core questions every year. And at least 2/3 of our survey need to include their core questions. And these are questions that we can't change. So that alone, that's what, 67% of our questionnaire that we have no control over, you know, what the wording is. And that includes basically all of their demographic questions too. So you can see here in 2003 for our high school YRBS, they asked one race ethnicity question, and Hispanic Latino was included all into this one question. And that changed over the years. Up until 2017, we were continuing to ask the two-part question of ethnicity and then asking about race. And you can see here that with the YRBS, they provided 5 answer choices, but there was no answer choice for students who didn't identify with any of these races. And as you saw with Mike and the other race ethnicity questions we asked, there's usually this, you know, something else specify where you can put how you identify, but that there are no write-in options for YRBS, so that's not something that we could have done. So we decided to, well, I'd say personally, this is something that I guess to be a bit more vulnerable too, this is something that's personal for me because as a Latina, when I look at race questions, I don't see anything that I identify with, you know, as someone who identifies as Latina. And so that's something that we also noticed with our data too, that with our high school, I believe it was our 2019 high school data, that it was, I believe, 40% of students who identified as Latino, they left the race question blank. So that's 40% of students who weren't, that we don't know what their race was and we don't know why they weren't answering that question. You know, for me, I know I would skip it too. And so we wanted to make sure that we could make this question more inclusive. Also, we're a bit nervous because it's a CDC core question and they may not let us change it. But to our amazement, we asked them and, you know, we told them, you know, we gave our rationale as to why, and they were very much willing to allow us to change it. So you can see here, this is based on our 2020 middle school survey, or now 2021 middle school survey. You can see here that the changes that we made to the race question is since youth aren't able to specify their race, we did want to actually include this last category here with another race not listed. And I also just want to note that we want to be mindful of reducing the usage of the term other for identities that don't fit into categories that are provided, because othering is, just another part of data that haunts us all and is rooted in white supremacy. And that is language that, we're still working on in all of our surveys. So we did want to be intentional about that. And then you can see we also added the Middle Eastern or North African category. And then I highlighted here in red that this will be the first year that we include Latino and Asian ancestry as well. And these would not be considered core questions. So these would be part of the, a third of the survey that of questions that we can create. And next slide. So lots of changes to race, ethnicity, but also lots even more changes made to our SOGI questions on YRBS, which is exciting. So you can see the first question here in white is the CDC core question that's asked. And this question still has not changed. This is the same question they've been asking the entire time. And that's a question that they would not allow us to change. So after, in 2017, our YRBS coordinator at the time and the child health manager at the time too, they did cognitive testing with high school students of various SOGI questions, and they were able to come to these questions that were added to the survey as non-core questions. So as you can see here under the white box, we have what sex is on your birth certificate. While it may seem similar to the first one, we thought it was important to include a question that we felt was more inclusive, even though, students would be asking more questions, we'd be asking more students about SOGI questions. We wanted to make sure that we were capturing more inclusive data as best as possible. We were also able to ask a question about if they describe themselves as transgender. And then also we have here our other gender identity, sexual orientation question. And we included a gender attribution question as well that is not shown here. And for the next slide, so that was for our 2017 high school, and we wanted to make sure that we made similar changes to our 2018 middle school questionnaire, and there was also cognitive testing done for this as well. And there were 2 questions that were added, and the language was modified a bit to fit the younger age students. And so I say all of that more of, just to broadly go over some lessons learned. There is more flexibility, as I mentioned, with CHS and kids versus YRBS, but I did want to, emphasize that it is possible, sometimes just asking, you might be able to sway them a bit. And, leadership buy-in is extremely important too, as Stephanie mentioned with Race to Justice, that happened, gosh, only a few years ago. And so, now having racism being more intentional and having more of an anti-racist approach in our work is something that, having that part of our health department mission is something that we're able to, hold our leadership accountable to when we want to make changes that we see as being more equitable. And that's something that we need their buy-in on. Space limitations, I briefly, talked about this as well, and being more intentional about not letting that hinder our ability to disaggregate. Community informed process, I believe Mike also briefly touched on this too, is just, we want to make sure that communities see themselves in these questions. And if we don't identify it with these novel questions that we're creating, who are we to create them without seeking input from the people who identify with that, with the question. So that's something that's very important in wanting to work more with our programs that we solicit questions from and the community-based organizations that they work with. is going to be an important part of this process. And then also just agency-wide collaboration, working again more with programs. And then we also have employee resource groups at our agency for various identities. So we have like a Latino employee resource group, Asian American employee resource group, LGBTQ, so forth. So working more with them to ensure that our questions are more inclusive and just keep abreast of larger agency-wide groups that are working on the same type of work. You know, there is an agency-wide LGBTQ task force, I believe, that is working on SOGI questions. So those are all things that we, you know, are mindful of and like to collaborate on.
April, I'm sorry, we had a question. Could you please reiterate what SOGI stands for?
Yes, excuse me. Yes, SOGI is sexual orientation and gender identity.
Thanks.
Okay. Of course, of course. And then in terms of briefly next steps, I mentioned in our last slide, just broadening involvement in our survey design process, working more with programs and community-based organizations, being more intentional with questions that relate to our agency's racial justice mission. Now that's something that we are specifically asking programs about when we solicit questions from them for our surveys. That's something that they'll have to ask, is how their questions relate to the agency's racial justice mission. And then just institutionalizing these changes too. It's great to do this, but if we don't hold ourselves accountable or, you know, incorporate it within our division goals, bureau goals, then there's really no way of really holding ourselves accountable to that. So that's something that we are trying to make sure that we're doing, is just institutionalizing this and embedding this in all of our work. And then, as Mike mentioned, for the CHS and for New York City kids, we are moving to an address-based sampling method. So that is also going to allow us to target more specific groups and ability to blend census with our ABS frame. So that can help us with, you know, taking more of a inclusive approach to our surveys. And so now I will pass it off to Martha.
And in the quick interim, I'm just going to remind people, please use the Q&A function. We have lots of questions coming in and they will be captured there and passed along to our panelists. So I see there's a lot of conversation in the chat, but if you wouldn't mind using the Q&A function as much as possible, that'd be very helpful.
Thanks so much. Thanks, Stephanie, April, and Mike. And we'll have some time to go over the questions after I present. So, you know, my name is Martha Alexander. I think that all of us in public health have an obligation to call out inequities and work to fight against them. I do believe that everyone has a right to optimal health and deserves to reach their full potential. So being data people, we know that we can use data to name and address disparities. This is a picture of me in my day-to-day job when we're not in a pandemic. I promote health department data tools and help internal and external partners get the most out of the data. Our aim is to help partners use the data to support their research and grant writing, policy formation and evaluation. But you can go back, please, there. And although this work has slowed down since March, it's been exciting to work with different community groups who are able to use our data in their efforts to make their communities healthier. When I speak to community groups, I usually start by explaining what data the health department has, how to access it, and how to use it. So today I'm going to speak to that a bit and then show some examples of how our data products reflect a focus on making sure that the data reflects our reality. Next slide, please. So here we are. The basic first step is finding the data on the health department homepage. So the data that the health department collects comes from the surveys that Mike and April talked about, as well as from disease registries, birth certificates, and death certificates. We make the data publicly available on our website. You can start at our homepage, which is nyc.gov/health, and you click on the tab that says data, that's outlined in yellow there. Next slide, please. When you click on that data tab, you come here to our data homepage. So you can also go directly here by typing nyc.gov/health/data. You see that our tagline is hundreds of stories, one place to start. We want this platform to make it easier to translate data into stories and to bring awareness to health inequities. On this slide, I want to highlight the 3 options on the data tab that are again outlined in yellow: interact and visualize, data sets, and publications. The interact and visualize tab takes you to our 3 interactive data tools. Data sets is a good place to start if you want to do analysis. You can check out the data catalog for a list of publicly available data. If there's data you want that you can't find, you can contact us to discuss the data use agreement. And finally, the publications button links to all of our data publications, everything from our annual vital statistics summary to reports with analyses of survey data. Next slide, please. So to talk a little more, as Stephanie mentioned, knowing the context of the data is essential. This text is featured in our community health profiles. As you can see, we include the historical context, as well as a reminder that health is influenced by structural factors. When we look at data by neighborhood, we're often reminded of historical context as well. So this map of diabetes prevalence is recent, but it really could be overlaid on older maps showing neighborhoods that were redlined. This data is from the Community Health Survey, and the map was made in EpiQuery, which is one of our online data tools. Next slide, please. Along these lines, here's an example from our online community health profiles tool. Here we're showing how rates of incarceration compare between 2 neighborhoods. One on the left, the blue, and then one on the very far right, the gray. The other neighborhoods are grayed out in between these 2. This is called a mini bar chart. When you're using the online tool, you can hover over each little bar to learn more. So the text above gives some context and reminds us to remember systemic factors when we're interpreting data. Next slide. We also write special reports in line with the goals of the health department and cooperation with community partners. These longer form reports give us more time and space to break out some of the data in a thoughtful way. The pullout here is from the Health of Older New Yorkers report, and you can see that we were able to look at the percentage of older adults who live in a household with 2 or more generations, and to look at that by race and ethnicity, country of birth, sex, and household poverty. The Health of Latinos report, pictured behind that, was significant because we disaggregated Latino New Yorkers by heritage group to break down the idea of a monolithic Latino community. Another report that's in progress but not pictured here is on the health of Asian and Pacific Islander New Yorkers. While developing this report, we've met with a broad range of community stakeholders to get their feedback on which indicators would be most helpful to them in their work. We're still working with these stakeholders as we're getting to the publication and distribution stages of the report. Some of the data used will disaggregate up to 13 different ancestry groups, including separate disaggregation for Pacific Islanders. Another example of disaggregation is this analysis of high school students and their gender attribution. You can see here that we measured gender attribution by asking youth how they believed other people at school would describe them. The data here was from the Youth Risk Behavior Survey that Mike and April mentioned, and this was published in a recent edition of our Epi Data Brief publication series. Next slide, thanks. I mentioned that we updated our online data tools last year. This was an effort to make the data more accessible and easier to use. So for community partners, for example. On this slide, I've detailed a few of the approaches that we used. First, we developed representative user personas based on consultation with actual users of the tools. Here we have Carla, the CBO director, and Rob, the reporter. Each of them had different motivations for seeking out health data and different skill levels when it came to interpreting it. We kept those folks in mind as we designed how the tools would work. To the right of that is an illustration of the principle of guided analytics, which is set up to guide users through EpiQuery. On every indicator page within EpiQuery, you start with an overview, and then you progress through menu tabs from left to right into more complex analyses so that anyone looking at it can start easily and not get overwhelmed. Another thing we did to make the data more accessible was to focus on using data visualization best practices and making everything mobile friendly. So you can actually look at a lot of our data tools on your phone. And on the bottom right, you can download or share or print the data from within the online tools. This has been great for community partners who want to print certain analyses for funders, or for researchers who want to put a deep link to the work that they're doing. Next slide, please. As I said, all of our data tools, data sets, and publications are on our website at nyc.gov/health/data. And if you have any questions about our data sets, you can email me at this email address, query@health.nyc.gov. Next slide, please. Thank you all for being here today. We've enjoyed sharing what we've learned over the past few years. Looking forward to questions. I know we've come a long way, but the ghost of aggregated data and the way things always have been still haunt us, and they influence how we develop survey questions, collect data, analyze data, share data. So we've become our own Ghostbusters of disaggregation, and we've learned to recognize when more inclusive, equitable approaches can and should be taken. I think it will take a long time to normalize these changes throughout and ensure that anti-racist approaches are no longer seen as the spooky alternative to the norm, because they should be the norm. Thank you. Yeah, and email us. Feel free to email us. We do want to continue to be in dialogue.
Wonderful. Well, thank you all so much for your presentation today. This has been so interesting and so exciting, and we have lots of questions in the Q&A. And so I am going to start to go through them. And for those of you that still have questions, please don't be scared. Put them in the Q&A. We have 30 minutes left to try to get to as many of these as possible. So Michael, I know you answered this question online, but I wanted to make sure that everybody got a chance to see it. The question was, I'm curious about what languages these surveys are offered in, and if you have encountered challenges of translating and interpreting the demographic questions.
Yeah, thank you. So for the community health survey, the survey is conducted in English, Spanish, Russian, Cantonese, and Mandarin, as well as Bengali and Haitian Creole. And we haven't noticed a lot of problems as far as translations of the demographic questions. There are other questions that we've asked that have definitely had problems with cultural equivalency. We tried including questions on social cohesion for several years, and there was always a lot more missing data for some of those items for non-English, and there were as well as English speaking respondents. I think mainly because we were asking about some kind of vague esoteric constructs, like one question was this neighborhood is close knit. That's close knit is kind of something that's hard to define and not easily translatable. But for the demographic questions, I think they work pretty well for the most part. There's always some missing data, but we do look at missingness by language, and it's not as big of a problem as you might think it is.
Wonderful. For the questions that we're dealing with children who were not born in the US, what about a child who was born to a US citizen serving in a foreign country under the military or foreign services?
I think that would involve asking additional questions. In the past, for the kids survey, previously, they had asked a follow-up question. How old was the child when they came to the United States? But we've never specifically asked about being the child of American parents living overseas. So that is a little bit of a limitation, I guess.
Have you gotten any pushback from parents on the SOGI questions in the surveys that are targeting youth? And if so, how do you handle it?
Hi, yes, I wrote an answer to this in the chat, but we have received pushback. From both parents and school administrators, we provide the questionnaire, specifically when we're talking about the youth behavior risk survey, we provide the questionnaire to the school administrators as well, so they can see it, to see if it's something they'd like to participate in. And I wouldn't say it happens a lot, but there are instances where, you know, there is some concern. And that's when we have to take more of an individualistic approach with each school to hear more about their specific concerns, talk about, you know, what we've done to create these questions. You know, we did cognitive testing with youth to ensure that these were questions that they felt comfortable answering. And I think it's important to note that, you know, that YRBS is special because it's the youth being able to answer these questions for themselves. And it's not like, you know, kids where an adult is serving as their proxy and answering the questions. So that's something that we try to emphasize. And again, you know, it varies. Sometimes there are schools that may not want to participate because of those questions or other, you know, questions that they may deem as sensitive. But you know, that's something that we have to work on, you know, on a case-by-case basis. But I would say that it's rare and it doesn't happen that often, though.
Great, thank you. Stephanie, I know you answered this question in the chat, but I think it's something that a lot of different groups are looking at right now. So I was hoping you might share it with us. What is the rationale behind the agency policy not to use the term Latinx?
I'm just gonna say quickly, this is really complex. And what we have found is that when we've done in smaller scale, like program evaluation questions in the field in a lot of our communities, a lot of people don't like recognize the term and are kind of thrown off by it, particularly older New Yorkers who may identify as Latina or Latino. So I think there's a generational aspect to it. I think there's also, as somebody, Tina Cow, referenced a Pew study about how a lot of people who identify as Latino or Hispanic don't necessarily know that term. So it's something that, again, we try as much as possible to remain grounded in how people identify themselves. But it's, you know, it's something we're paying close attention to and are trying very much to, and I also want to be clear that this has come up in other languages as well. How do you, if you're talking about gender identity and gender neutrality in languages that have like a strong gender basis for pronouns, it's really complicated.
Wonderful, thank you. So Michael, I know, again, this is a question that you answered online, but I want to bring it up in particular because in addition to what you are saying, this allows me to promote one of our future workshops. The question is, were there any challenges when you revised the race ethnicity question, specifically when adding the Middle Eastern or North African response option in regards to how weighting was conducted? Michael, I'd love to hear from you, but this is also, weighting is going to be its own workshop in a few weeks. And so I just wanted to make sure that everyone was aware that there will be additional work in this area. But Michael, if you would.
Yeah, so, you know, we added this category and then, you know, it's a little bit of a double switch because then for weighting purposes, because the control totals are based off of census and ACS data, that data is typically coded as white if they identify as Middle Eastern, North African. So we're kind of stuck with weighting them to the white group for now, although we still have the ability to look at it by Middle Eastern, North African if you were looking at different health indicators. So that is one challenge of adding some of these new response items. That's a great question though, and hopefully something in the future that we can figure out some sort of methodology to deal with.
Excellent. Michael, you also answered a question on how granularly are you able to show small numbers in the New York City Department of Health and Mental Hygiene reports to prevent disclosure of individuals, and what guidance do you use to determine how small a cell size can be?
So I think this question actually might, if Amber, if you want to pitch in, our
Sure.
youth director, he deals a lot with these types of issues.
Yeah, my name is Amber Levanon Seligson. I work with this team. I'm in the surveys and data analysis unit. And so when we have reports or when we report out aggregated data, we do use reliability criteria. So these are statistical reliability criteria. And they don't have as much to do with cell size as they have to do with confidence interval widths and relative standard errors. So we have a kind of statistical set of criteria for whether we say that we have a reliable estimate within a particular population. And when we provide line listed data sets, some of the questions have been about, can we access these data? And the answer is yes. And so we have some data available on our website that you may have had a chance to look at. And so we put data sets on our website. Lots of students use these for many wonderful purposes and other people as well. But these data sets generally are not complete data sets. And so there are elements of these data sets that we then provide only with a data use agreement. And so an example of that would be when we talked about ways of asking race ethnicity, we also mentioned we have ancestry questions and more specific questions about origin. So those are examples of variables that we provide only under a data use agreement when we're giving out the actual data sets that can be analyzed.
Wonderful, thank you. And again, Michael, I know you answered this question. Can you speak more to ABS versus current sample methods and how ABS is more inclusive?
Sure. So historically, we've used an RDD, random digit dialing methodology, where landlines and starting in 2009, cell phone numbers were randomly generated within the New York City geography using New York City area codes. So the survey has always excluded households that don't have a telephone. It's a very small population, but it does exist, and we did have some questions that could be used in the weighting process, such as, if you've gone through a time in the past 12 months where your phone service was cut off. So this was kind of treated as a proxy for those households that couldn't be contacted because they don't have a telephone number. The cell phone problem is actually bigger because we estimate about 9 to 10% of New York City residents, myself included, have a cell phone number that is not related to New York City at all. I'm from Utah and I still have an 801 area code. So we've been able to develop a methodology with our vendor to sample a portion of those numbers based off of zip code billing address, but it's still missing a lot of people. So the ABS is different in that it provides almost 100% coverage of all residential units in New York City, because it's a sample that's drawn from the U.S. Postal Service's delivery sequence file. So it's pretty near universal coverage. So as far as coverage, we're going to be in a better position. As far as response, we did a pilot earlier this year using the new methodology and saw quite a jump in our response rates just by using the protocol that we had developed with our vendor, and allowing people the option of choosing for themselves how they want to answer the survey helped as well.
Great, thank you. So this question is for everybody, and maybe even some folks on my UCLA colleagues might want to jump in on this. What are some of the arguments for persons opposed to data disaggregation?
I've been wrestling with how to answer this one in the text. I will say this is not something I've actually heard of in our experience. I haven't heard of people arguing against data disaggregation. And so I was thinking, like, my initial response was like, well, can we just argue for like aggregating and have like shift the conversation to like how we aggregate the data once we've provided all these responses? So I'd actually love to hear a little bit more about the question was, in Los Angeles, some groups are opposed to dividing, quote unquote, the Asian group. So if we could hear any more about
that. So one of the one of the responses that we're getting in the chat is that they've been getting pushback from folks that need to collect this data in an acute care setting regarding the number of clicks to deal with it, regarding asking tough questions. So that's been some of it. We also have heard a couple of very anecdotal things, I will say, but we've heard, for example, several years ago, when there was sort of maybe the beginnings of the push to disaggregate in the white population, particularly the Middle East, North African populations, that after 9/11, some of those communities weren't that interested in being pulled out of the greater white community. We have also heard that outside of health, there are other areas in which there are concerns about disaggregating data and its interrelationship with affirmative action. For example, again, this is very anecdotal, but there are Asian groups who would say, well, as Asian groups, if we are benefiting from affirmative action for educational seats in higher education institutions, we don't want to be further disaggregated and have one population maybe lose out to other Asian populations if there are organizations that are really looking at numbers. So, those are isolated, but we're examining what the pushback is and what the concerns are, particularly as it relates to health, and whether or not it's coming from, as the respondent pointed out, it's the burden on the collector's side, or whether or not there is pushback from the communities themselves about this.
Yeah, so I feel like I say this for everything, but it's complicated, right?
Yes, agreed.
And I will say that one of the things that we've noticed on our end is trying to make sure that we're not, and we don't always do a great job at this, but trying to include training of people who are doing the collection as well as changing the instruments, right? I think it works really well in settings where, like the large research settings, which you get in which you get to interact with people who are, they're vendors, they're really trying to support your work as a client. In a clinical setting, yeah, that has been very complicated. People don't want to go through all the questions. There's also pushback on, there's lots of different kinds of pushback, but I think one of the things that we've found, particularly around SOGI questions, is that training of people who do the data collection is really, really important. And it's just as important as asking the questions. Do folks want to jump in on other things? Sorry, I kind of took that one.
I'm happy to just, I'll bring up another spooky topic of politics, but just say, we're talking about more of the data side, but, who would be, using this data to inform policies and whatnot. I think that's when it comes into ensuring that, that it's so important that we elect local, state, national, political officials who understand how to use this data in a helpful and not hurtful way. I think what is also helpful with disaggregation is that you can disaggregate, and if needed, you can always aggregate back if that is what is helpful for you. But if you only aggregate, there's no way to disaggregate. I just want to put those two things out there.
That's a very good point. So I think we've probably got time for at least one more question. There is a lot of concern that some immigrant communities may be less likely to respond to surveys due to fear related to immigration policy. What approaches do you use in New York City, if any, to ensure representation of these communities?
Well, we have noticed in our telephone surveys, and our vendor has said that this is something they're seeing with other agencies that they work with, that there has been a slight dip in Spanish language interviews, and we don't really have a lot of data to inform us why. It seems like the current political climate could have something to do with that. Moving forward, for our surveys in 2021, we're going through the process of getting a certificate of confidentiality and then trying to explain what that is to the respondent. It's a certificate from the National Institutes of Health that they provide them mainly for federally funded studies, but they also provide them for local studies that don't have federal money. That basically assures the respondent that the data or any of the identifiers that could be linked back to the data cannot be subpoenaed by a court and cannot be used for law enforcement. So we've been working with language to include in some of our MELD materials that we'll be sending next year that provides some reassurance about confidentiality and about, you know, this data is not going to be used for law enforcement purposes, but do it in a way that it's not actually going to raise concerns from people who may not have even thought of that. So that's one way, but I think that is a really valid, that's a valid question, a valid concern.
Yeah, just to add on, outside of the surveys, we're trying really hard on like program evaluation work to make sure we don't include, so like for the SOGI question, right, the standard is to ask people how they were identified on their birth certificate for, yeah, as male or female. And so trying to change the language around that to take out the word birth certificate and make sure that we're like not including any language around birth certificate or identification unintentionally in any of our questions.
We to add on to that and what I had just said, Stephanie, we were also letting respondents know in the invitation letters that we'll be mailing out that we are not collecting any data on citizenship. And I think that that's important. We do ask about country of birth, but we don't ask how long we haven't been asking for a while, how long have you been living in the United States, or what is your citizenship status?
Ninez, would you like to share how we do that in the California Health Interview Survey?
Yes, sorry, I was also adding things on the chat for resources. Thank you for the excellent presentation. I think we also have the NIH Certificate of Confidentiality. I have videos that show we will not report any of this information to immigration authorities. We, it's not just about the questions, it's the preamble before the questions that are very important, and the fact that it's also done in language. I think there's a little bit, we're a little different from New York because you're a government agency. We are not. So I don't know if that's helpful for us because we're branded as we're a university, and so we say we do not. So that might be a little bit of a challenge because you are a government agency. But we do ensure that if the data cannot be subpoenaed. No, we can't, as what Michael was saying. I think there is a concern though that with the anti-immigrant climate or the policies that are not pro-immigrant, I'll put it both ways, that there is, as we hear from APOR, the American Association of Public Opinion Research, and from colleagues through the national network, that there is a systematic non-response that we're seeing, that there is a chilling effect in the survey, in our sampling. So that is happening. And I know in CHIS, we're certainly seeing the immigrant population is all the SES characteristics seem to be moving up in terms of being favorable. And I know that that's being seen in some other surveys, federally, and some other surveys. So that is definitely a concern. And so working with communities and getting the trust and working with stakeholder groups is really important so that they have faith that the survey respondents is really to help improve their lives and improve their health. It's not to target them, profile them, penalize them. So I think that message really has to come out.
Yeah, and I'll just note that government distrusts isn't new. This is something that has been around for a long time. So this runs deep. This is a very deep wound in a lot of communities of color. So much of what we are trying to do now may not make that much of a difference. To be quite frank. And it makes sense as to why people don't trust the government. And yes, you are completely right. As a government agency, I definitely think that impacts the level of trust that communities may have towards our surveys. So it is something that we always have to constantly work on. But it's also something that I know is going to take a very long time and is a very concerted effort of us trying our best. But we came into this thinking that we were going into public health, but it turns out we are also in politics. So, that's, I never intended that my job would, end up being so political. So, there's just so many other factors that come into play that are out of our control as well. So, we can only do as much as we can.
Well
We're doing
said.
a lot. So you're doing a lot.
Yes, as evidenced by today. Stephanie, Michael, Martha, April, and Amber, thank you so much. This has been a truly excellent. I have been getting emails and comments in the chat about how wonderful this presentation has been. Thank you so much for sharing your time and your expertise with us today. And I also want to thank my colleagues, Tiffany Lopes, Dr. Ponce, Dr. Babby, Dr. Shimkata, who have been helping out on the side to help with all of the technical aspects of this and to make sure everyone's questions get answered. I appreciate all of your time today. As a reminder, this workshop recording and these slides will be made available on our network website, so please visit there. We will also be sending you an email with a post-workshop survey. And let me remind you that we are asking for feedback on what other kinds of technical assistance you'd like for your specific projects. We really want to be helpful and be a good resource to you, so please give us some feedback. Unlike the Halloween hunter moon that won't come back for another 19 years, we are coming back in 2 weeks with the next great workshop and strategies in mitigating disclosure risk. We had questions about that today. We're going to take a deep dive into that on November 13th. I apologize to those of you who maybe didn't get or missed an email that we have updated the link. If you registered for these workshops, you are registered for all of them, and there is one link, but we had such demand that we had to upgrade our Zoom. And so there is a different link. The original link you were sent doesn't work anymore. The new link that you got in with today will work for the rest of the workshop. So please join us in the future. And again, if you're not able to make any or you miss any, we will be putting them up on our website. So thank you so much for joining. I hope everyone has a wonderful, happy Halloween weekend, wherever you are and however you're able to celebrate. And that we'll see you on a future workshop. Thank you very much.
Thank you.